Philip, can you hear me? Christina, can you hear me? Can you hear me? Christina, can you hear me now? Can you hear me?
I can hear you.
Oh, perfect. Thank you. Thank you, Christina. Thank you.
Hi, Cyclist.
Hello. How are you?
Sorry, we're eating.
Enjoy it.
we're gonna be watching you and eating. We have Uzo in one hand. And
I hope
Jean in another.
everybody else can't hear us.
Can everybody else hear us?
Yeah, they're all coming in. Just 1 second. There's people coming in. I'm just trying to.
Can you hear the
Cheers, Sarkis.
Cheers. Thank you. Cheers.
Can I unmute now?
Yeah. Just waiting for a few more coming in. There's a girl called Jennifer coming in. Whoa,
Can you hear me? Can you hear me, Sarkis?
I can hear you.
I want to get muted. How do I do that?
I'll mute you.
Oh, you mute me then.
I'm just waiting a couple of more coming in, so I do apologize. In the meantime, we couldn't go about the replace the lateral missing incisor. And those of you who have a lot of interesting ideas, we'd like to talk to you, we'd like to challenge your ideas. I'm just waiting for a few more just coming in. Is anyone got any questions to ask before I start the lecture? I'm happy to take on ideas. Anybody at all? Let me pick somebody. Isidora, would you like to say a few words? What would you like to? Now we talk about the missing lateral incisor, and any comments so far? Isidora.
Comments. Missing lateral incisors. Yeah, unilateral Sarkis or bilateral?
It doesn't matter.
I think it's always complicated if it's unilateral.
Mm-hmm. We're talking about post-orthodontics. Although I'll talk a little about orthodontics, but we talk about post-orthodontics. Oh, here we are. So it's important to, I'll talk about, I will slightly touch on the orthodontic side because we have a lot of aspiring orthodontists in the practice, so in the participants. So this is a very exciting topic. I think it's one of the most exciting topics that will change your paradigm today. Can you hear me clearly, by the way?
Yes.
Thank you. But Izzy, what would you like to suggest? I mean, we're looking at seven number 5, right in the middle on the lower. I've got just a few more coming in. I'm trying to meet them all. But it's interesting to know that, you know, we evolve as a profession. And what we knew a few years ago, how it changes. And sometimes when I graduated almost more than 30 years ago. So we used to do some other treatment missing lateral incisor. It was required fixed. And the world went around and around, and so we're coming back to the same concept. And now, naturally, we have more adhesive technology. So we're going to talk a little bit about adhesive technology. We look at some data. So it's a sort of idea to challenge your ideas about when you decide to treatment plan patients. As a prosthodontist and implant surgeon, I like to look at the most conservative options in treatment planning for my patients because it's very important. And we'll talk a little bit more on that. So I'm just getting a lot of people coming in. There's a lot of interest today. So, and in many ways, how we see our treatment plan as patients present. And as you can see, this is the 5th of the 6 webinars I'm presenting on behalf of the college. And the idea of the college is share our knowledge. And this is given to you at that special basis. Here comes Victor there. Thank you for Victor Jogner. Now, one thing I like to say about when a patient presents in your practice, and this female has had a adhesive resin bonded fixed the partial dental prosthesis in situ for over 15 years or 14 years, it makes you think twice about looking at other alternatives, because one important aspect of dentistry is the fact that we feel that before the implant was was the most appropriate option. And before that was the conventional bridgework most appropriate option, where we used to sometimes prepare two good teeth to replace the lateral incisor, or having a partial chrome cobbled cast framework retaining the removable prosthesis replacing single or two laterals. So in many ways we need to think about there've been a number of issues. So I'm going to go with this and keep talking a bit more. And so write me if you need to write me. You can stop me, ask me questions. An open forum. It's not about my opinion. It's about your opinion. I'm here to discuss cases, and it's going to be very interesting. So let's go next stage for the patient. As you can see, patient presents for a number of. What do you think will be this patient's chief complaint? Anybody take us? What would that chief complaint for the patient? Okay, let me ask question. Okay, the chief complaint. Okay, so let's talk about this. What would the chief complaint for this patient?
Aesthetics.
Aesthetics. Okay, what else? Okay, and aesthetics would be what?
Are we looking at which slide exactly, Sarkis? I see 6 slides.
But two letters are missing. That one and that one. Okay. Aesthetics. What does aesthetics entail?
Are you pointing, Sarkis? Sorry, which one and which one?
Okay, these two are missing. That one, 1, 2, and 2, 2. Okay.
I'm just saying. Sorry, Sarkis. I've seen 6 slides.
Which slide? You're seeing 6 slides?
Yeah. I'm on the introduction.
Hang on. Let me just think. I apologize. Am I sharing the wrong? Are you seeing the 6 slides? You got this one? What do you see there?
I see 6 slides. What does it mean to lose a tooth? A loose crown?
Just like a resume share. 1 second. Just a second.
That's it. Okay. Yep. Single screen now.
Can you see that now?
That's it. Perfect. Yes. Perfect.
Wonderful. Okay, I'm so sorry about this.
No problem.
Okay, so aesthetics is an issue. Let's go next one. Okay, so chief complaint is aesthetics an issue. What's aesthetics? I mean, what would be aesthetic complaint for this patient? Dinesh, you can come in too.
Yeah, I got 2 big front teeth. Every time I smile, they can see 2 big front teeth, or 2 side teeth sticking out, or my gums don't, because of course she has got a gummy smile, so she might say that I got 2 side teeth not looking as good as the other teeth, because the gum so showing too much gum, 2 side teeth sticking out, got 2 big front teeth, so every time I smile I can see more of the 2 front teeth.
Okay, let me give you here. I'm going to go back before. So what do you see here?
Yeah, that's just the cantilever bonded.
Yeah, what's this one?
Yeah.
What's this? That's a what? Rexilium type metal, right? It's a non-precious metal, right?
Yeah.
Okay, so what would this be causing? Have a look.
Oh, I mean, wearing off the bottom teeth, is that what you mean? Or in terms of the...
You mentioned about aesthetic concern that I've taken on board. You mentioned big teeth. What other concerns would the patient have?
Discoloration.
I'm sorry?
Discoloration.
Discoloration. Very good. Whereabouts?
Where the rest is, where the...
Yeah, it's correct. Discoloration, the general discoloration. Okay, I accept that. That's accepted too. I mean, part of the aesthetics. So what other concern would, I mean, you can't see it too well in this slide. That's why it's a tricky one I'm showing you. What other concern would the patient have? What's a usual concern that people have and they refuse to do that with resin bonded bridge work? We're using metal retainers. What was the thing that metal retainers caused?
Allergy.
No, don't worry about allergy.
No, sure.
If this person had allergy, that bridge would not have been there for a long time. So what we know.
Yes, true.
Is it the opacity, Sarkis, caused by the the framework,
Not opacity, something else.
or the grayness.
Always biting, always biting on the metal.
Got it. Got it. Gel discoloration. Okay, and you got the metal frame, and you got the grayness, correct? The grayness. So that's a big concern for patients, and this was the issue that a lot of us refused to do this type of bridge work for a lot of the patients. Okay, but we have so much data. We have over 30-year data. How are you, Steve? So 30-year data on resin molded bridge work. Okay, where most of the problems that we see with implants and prosthetics has been to cause a lot of problems, and I'll talk about later. I'm not about implants, but we'll talk about the simplicity of the treatment. I mean, the whole idea in my practice as a specialist is to simplify the treatment, make life easy for the patient, but also for me. And when you try to do a treatment plan, you complicate it. Remember, every complicated treatment plan has got a higher financial, high maintenance, and higher biology cost. So it's important, like I always say, before we say something to the patient, we think about it. So I like to think about it before I talk to the patient. I just want you to think now. I've got you those two lower pictures there. You can see the lower, there's two side pictures besides the occlusion of the maxillary anterior area. What else do you see on left and right? What else do you think will be a concern for the patient?
Hard to clean.
Hard to
Very hard.
What's happening in there?
So we lost the papilla there. You can see the.
Okay. Lost the papilla. Okay. I'm going to come back to that. Can I regain the papilla?
Yeah, black triangles.
Can I regain them?
Yeah, black triangles.
Can I regain them? Can I recreate the papilla as before?
Of course, you can guide the papilla.
You can guide it. Okay, good. Okay, how would I know?
Well, not in a current situation, but if you pretty much, of course, give I don't know whether it's easy to do or like that, but of course, once you create a new pontic, I don't know whether pretty much we can direct the gum and people try. It's not easy.
Okay,
but
ask you a question. I'm going to just direct the question here.
Yeah.
What test would you perform? It's a bit complicated. What test would you perform to give you almost 90% guarantee that you can regenerate papilla?
Okay.
Any takers? Anyone? Just give me an idea. What would you do?
Measure the height from the bone crest to the contact.
Very good, Jennifer. Very impressive. That's who wrote that article first time in 91. Tell me if you know it.
I'm not too sure.
Was Tarnoff, 91, 92. Tarnoff and Fletcher wrote that article. If it's within 5 millimeters of bone crest, you got a 100% chance of regenerative papilla, whether it's an implant or a tooth, basically. So I'll make a probe, I go in there, yep, I'll regenerate it. No, I can't regenerate it. The only time I can't really regenerate papilla, and I'll tell you later on, because you can see in this case, there's a reason for that, but I'll come to that in a minute. That's good, very good so far. So there's Nimesh said initially that the other problem was food impaction on the ridge, because the pontic, not the pontic, but under the pontic has remodeled ridge. So why would the ridge have remodeled for this patient? Do you think pontic caused it? Why? Why? It was, looked pretty good.
No tooth there, Saka, so we get remodeling of the ridge in the lateral incisor area.
Okay, there's no tooth there, so, okay. But Derek did a good job. I mean, how did he manage to get such a good wide bone thickness, in your opinion? How did he manage to do that? So if you're an orthodontics, I mean, Nimesh, you do ortho, Kristen, Howard, Kristen, you do orthodontics. Is there anybody else that does orthodontics besides those three in the crowd? I mean, Catherine, you do ortho.
Yes.
Right. So, how would you create a bone width if you're missing left incisor?
Good question, but I'm not sure if I'm answering this correctly. But
Let me ask you the question again.
okay.
Your patients around about, well, when you discover there's a laterals missing, roughly, which age?
When? Oh, you detect it as soon as the age of the tooth is erupting, so pretty early.
How early?
I would say, well, it depends on when you take the OPG, but the tooth.
When would you take an OPG? Which age?
I would say between 8 to 10-ish.
Right, round about, so laterals erupt about what? What age they erupt?
Yes, yes.
7 years, yeah.
Which age the laterals erupt, roughly? Nimesh, hurry up.
Erupt around 7 to 8. Yeah.
7.
Round about 7.
Yeah, around about 7. I would take an OPG around 7.
Right? I'll take an OPG at 7. I mean, we don't treat
Yeah.
It's a logical approach. Okay, good. Okay, might even take earlier sometimes. If I think the mom has got laterals, so I look around the family, oh, mom has got laterals, we better take an x-ray. Now, that's immediately I'll know. Okay, so I'll tell the mom, you got laterals missing? Yeah, I had a second, fine. Let's take an x-ray. So even earlier with that. So you discovered at a young age, and you're doing the orthodontics. I mean, I don't treat children in this. I don't know. I do adult ortho very mild, but okay. So what would be your treatment plan? You're managing the case of this patient. Catherine.
Well, depends on whether you want to preserve the tooth. So in this case, that we want to preserve the tooth, or are we bringing the?
We haven't got 2, 1, 2, and 2, 2. They're missing. Both teeth are missing.
Yes, but my question is that do we want to bring the 3 into the tooth space, or do we want to open it to do the breach?
First of all, let's say, so I can continue the conversation. Let's say you want to create the space, and we'll discuss why, but let's say we want to create a space. So what would you do to give you a better alveolar width?
Tip the roots slightly mesially into the lateral space, and then you can upright it later. But
A bit more than that.
Or you can move the 3 into the tooth space and then move it back.
Excellent. You know who wrote that? Cockish wrote that back in 1986. It's a famous article. And one important thing, he talked about serial extraction, where he takes the lateral canines, move in there, and then the laterals, he just retracts them. In many ways, you can actually decide at the time where you want to have a no treatment, a minimal intervention treatment where canines are approximately the centrals, and bring the premolars forward and tip the premolar neck and create all sorts of things to simulate canines, and 5 becomes a first premolar. That's quite fine. But from your point of view, why would Derek in that case make the space for lateral incisors? And it's the right trim, by the way. Why would you do that?
Is it something around canine guidance or something, just to get that instead of having a?
That could be a good point. It's a valid point, and I accept it. But it's the sort of thing that that would have been the number one driving factor.
I think no matter how you do by trying to replace in the canine, trying to replace the lateral with a canine, it's never going to be the same. So I think it's always nicer functionally and aesthetically if we can keep the canine in the position and restore the missing tooth.
Okay, I agree that with also, and there's a good data that gives us this concept. However, if you look at this patient, the age 27, 28, if you had brought the canines towards centrals, what would she look like?
I wouldn't say very pretty in terms of, because I think we lose the gum there. We lose the gum there because the canine's got a big root.
She would have a full smile. She would have a full smile, okay? And resulting aesthetics would be compromised. Would you agree?
Absolutely.
Thank you. So we all agree on that. So in a way, aesthetics was an important driving factor for the patient, correct?
Yes.
Right. Okay. So having said that, I'm just, before I go to the next slide, just to answer Jennifer's and Catherine's questions. Where would you approximate canines to the centrals? Jennifer.
Sorry, what was the question again? Where would you
Where
approximate?
would you approximate canines to the centrals? Or Catherine, we can answer to one, we can answer. I'm happy either way.
Oh, I would say that measuring the golden ratio of the relation between how big the width of the central as compared to the width of the canine, and then proportionally to make the space for the lateral, add a little bit of the interdental space for the how do you call that, the papillary space, and then you will restore that space for later, which you will be able to restore it prosthetically.
Okay, but the question was, when, under which circumstances would you consider approximating canine to the central? So can anyone answer that? When would you, what situation would you have the canines next to the central? This next to here, and this one next to there. When?
Missing lower centrals or missing lower 5?
That's another point. What else?
I would look at the lip line and the smile line as well. If they got a lower lip line and pretty much there is no gummy smile like this, that means not everything is on a display. So if there is a...
What else?
Yeah.
Okay, looks like you're not getting that. The most important thing is the anatomy and color of the canine in relation to the missing lateral incisor. If you have a really small canine, like a reshape and add, and it's within the color, you can bleach them by the way, but the shape is what size is important. Then you have a good chance of approximating, because the important part of it is to be able to give the patient a treatment that's minimal maintenance. So the option and the consenting part to be to the patient, look, we want to give you the best of minimal maintenance, provided you can bring everything anteriorly, create a good arch form, etc. But that was a time, and the decision was made correctly for this patient by the orthodontist. And the trouble is, she's now wants a replacement. And initially, she was told that this is just temporary restorations. It lasted more than 14 years, the temporary restorations. I wonder how many implants last that long, okay? But that was a long-term provisional restoration that lasted 14 years. So having said that, let's go next one. So, we have a good assessment, we've got good periodontal stability, the bleeding is less than 5%. What would be the reason for me to tell the patient in this particular situation that, I mean, perio is okay. Has anyone got problems with periodontal? I mean, it's good bone level. I look at the joints, they look fine. Can't think of anything else. I'm going to move to the next slide. But just looking at the floor chart of the missing lateral incisor. So a lot of this floor chart gives you all the ideas of all the things we talked about. And if you look over carefully, adhesive reservoir bridge, fiber reinforced, porcelain metal bridge, implants are probably the last one on the side. Okay, so just to give you a heads up here, implant is the last thing in there that needs to be done. And we knew this a long time ago. And yet today, implants are the first treatment of choice for most dentists. Okay, let's move to the next slide. So what do we see for this patient? What do you see in this x-ray? Let's talk about it. Who would like to take this on? Let's start. How do we examine OPG? Let's talk about it. How do we examine OPG? What do you look for? What do you look for first?
The number of the tooth present.
Okay. Do you always look at the teeth first? Because I don't. I'll tell you what I look for. I look at the joints. I look at the sinuses. Okay, that's number thing. I want to look at the teeth. Is the last thing for me.
And the bone height?
Then the bone height, yes. And I look at the septum, look at the inferior concha, middle concha, look at the maxillary sinuses, they seem to be clear. I'm looking at the board of the mandible, it's all intact. The inferior canal, it's all intact. Looking at the temporomandibular joints, what do you see there? What do you think? Does that joint look normal to you? Is that a normal joint? Any takers?
It looks one side is rotated and it's not symmetrical.
Okay, which side?
On the right.
On the right. Right. So why is it different to the left? I'm enjoying this, by the way. It's interesting, isn't it? See, when I'm looking at cases, I look at it so differently. So why do you think, Isadora, where are you? You were taught by the famous TMJ or TMD specialist, who we won't name, you know, and we had a dinner together, and the technician was adamant that all TMD patients should be in phase 1 and phase 2. We bring them forward and get their joints, discs captured, and then you build a full mouth reconstruction at that level, because it's an American, it's the best way to make money. It's a fantastic way to make money, but it's all absolutely caca el doro, I can tell you. So,
He's biting on the right side more. When you look at the central incisors and the lower central incisors, the bite itself is towards the right. So
what's into the right joint then?
Because he's chewing on one side and trying to move the jaw to the other side, and then the FPG was taken.
Yeah, I want the word. You're right. What's he doing? You're right. You're on the, I want one word. What's into that joint? Starts with L.
Starts with L.
L. It's
Luxated.
It's loading.
Loaded. Okay. Right.
It's got no TMB. It's
Yeah.
loading. Why is it flat? It's an adaptation response. It's adaptation response to the loading. That's all there is to it. And yet the patient was told that you need to have a major joint problem because your joint is not normal, it's not symmetrical. You have to take a CAT scan, you have to line your bite to get it right. What a rubbish. No such thing. You understand the concept? So when I talk about different concepts of people with LVI and all these other people belong to some sort of other different religions, there's no basis for that. Okay, I'm just going back to the lecture again. Now, during the course, when we talk about the occlusion and TMB, we discussed in detail, very much in depth, how to think, what's your rationale behind your decision making. So we see the joints, is it normal? Yes, it's normal, okay? And we look at maxillary sinus, it's normal. What else was I looking at? Now coming to the teeth, Catherine, you're there. Now we're looking at the teeth, correct? So the patient was told after 14 years, this temporary bridge after 14 years. I like to call it temporary because that's what she thought was given, temporary bridge. And I'm very impressed how long this temporary bridge lasted, as expected, by the way. What do you see here? Talk to me.
I see the beautiful mesial tilt of the root of the 1-3, and it makes it hard to put the implant there.
Mm-hmm. Do you think it was finished this way?
You mean deliberately, orthodontically?
Yeah, you think it was finished this way?
Oh, I don't think so.
No, because this was pretty good there. So what happened here?
It's loading differently, so the root is tilted by the top.
Loading good from the right side, that's right. And Sid Bashir said is loading on the right side, exactly. So I'm trying to make you think that when it comes to the RPG, you can predict a lot of things we will see clinically. We can tell. Sometimes I supervise a number of masters and diploma students. And the interesting fact is that bring me x-rays and give me other clinical images when I know that that doesn't correspond to one another, because I can pick it very quickly. That's how we get examined. Just examiner, we look at the students and we know exactly which case is going to go, you see. So that we just want to see that everything's been done in the mainstream with respect to the facts that was gathered during the clinical and radiological and other testing processes during the examination process. But the fact of the matter is, you're right. So it's tipped medially, and the good chances are, as Sid Bashir said, because it's loading on the right side over the period of time, it could have moved it orthodontically, correct?
Yes.
Right, I agree. And in that, so from that point of view, if you go back, if you just go back, you can see on the right, there's more of a gap between the pontic and the ridge, and less of a gap between the pontic and ridge on the left side. Does it make sense to you?
Yeah.
Okay, it's going to click in because common things occur commonly. All right, so let's just go back to our lecture. Okay, so what would you do? The patient says, well, I need an implant now. Where do we go from here? Nimesh, what would you do?
I would say I'm not sure whether I can suggest you for an implant or anything. Let me see what I can do.
Okay.
First, I would probably trying to tap in what actually bothers her before trying to give her a solution.
All right, fine. Let's say, okay, based on so far speaking, what were your first choice? What was your second choice? Or replacing this with fixed restorations?
Of course, my first choice is to get her the aesthetic what she wants by giving a quick fiber bonded bridge, which is with the support of canine and the central, and get the gum symmetry right, get the pontics looking great, get the matching right, do the teeth whitening, make her feel comfortable, see where she is. If she likes my fiber bonding and things like that, maybe down the track, I would tap into implant or refer if it needs to be. But I won't personally suggest implant in this sort of case to start with. Yeah.
You mentioned about the resident bonded bridge going from 2-3 to 2-1 and 1-3 to 1-1, correct?
Yeah.
But look at the design here. It's a single retainer. Lasted 14 years. So why would you change the design?
I mean, of course, it depends on the, this is bonded with the metal. I'm not sure with the fiber bonded. I'm always a little bit wary about doing a cantilever on a fiber bonding. Yeah.
We're going to come to that. Okay.
Yeah.
Let's say you're not thinking fiber bonded. Obviously you're thinking fiber bonded, which I understand. Okay. Okay. How would you tell the patient she wants dental implants? How would you tell the patients that maybe dental implants are the first choice in this situation?
I mean, see, rather than I say, no, you can't have a dental implant, I would rather say that probably, yes, we want to do the dental implant, but it's not an easy solution here. There are a number of things happening here that may need to be looked at.
Okay. Let me just answer it. Okay. Yeah. Let's take on the implant road. Let's say you can put an implant there, argument's sake, okay?
Yeah.
Okay, what dimensions of implant bone height and width or volume do you need to put 3 millimeter, the narrowest implant that I think is what you need?
Well, you need at least 4.5 millimeter of width there as a bare minimum. And pretty much height-wise, we are fine there. Height-wise, there is no issue there. The trouble is the contour of the tooth. It's not about the diameter of the implant or anything. how we gonna get that cervical contouring as a final restoration on an implant. I think we're gonna lose more gum than what she has got now. As soon as we place a dental implant, I think we're gonna lose that tissue there.
Where would you lose the gum?
Of course, distal of 1-2 in this situation, distal of where we already have an issue with the gum or the papilla there. I don't think with the 3 millimeter implant, with that diameter, we can retain that papilla. It would be very tricky.
Okay, you see, okay, okay, just question. You need minimal 5.5 to 6 millimeter of bone width, bone volume all round, in other words, so that even if it's 3, you want enough width. So I could get away with 1 millimeter each side, so a minimal 5, but
yeah,
with the accuracy of placement, I need a bit more than 5. I like 6 millimeter, that gives me a safety zone. So
yeah.
6 prerequisite for me to put 3 to 3.5 millimeter implant here, because you need that much, because it's a high aesthetic area, high gum lines, scalloping margins, a relatively moderate biotype. So I'm at risk having any grayness showing through. There's a good chance of the grayness will show through. So I would say from the tissue management point of view, even if you have a high volume of bone and other things, high smile line, my safe bet would be to copy the original design and improve on the original design. It's been there for a long time and it's done very, very well. One of the important things from the implant support restoration is the fact that what really happens here is that during the patient's growth, if they're dolicho facial growth, they're vertical growers, they basically have quite a step in the process. Now they have hyperocclusion and it becomes quite anesthetic. There's nothing you can do about it. So when you put an implant in a bone, that bone freezes in time. That's the end of it. Okay. You understand that implants do not preserve bone. Okay. Bone doesn't give a rat's ass if there's implant or not. Bone will go where it wants to go. Okay. Implants is an artificial device that breaks down that area of remodeling of the bone. So I read an interesting article Dennis wrote on their website. The fact that an implant preserves bone. There is no such thing. It doesn't. It has nothing to do with a bone preservation. Okay? It's as simple as that. It doesn't. Now, there's no doubt that implants preserve bone. Biog studies in the 60s, he placed a lot of little tantalum implants in the jawbone. They all took off in the kids during the growth phase. Now, so existing reservoir which is in situ for age 40, so a long time, 15 years, long time.
Yeah.
Long time. Okay. How long do implants last? God knows. How many implants are removed in these positions? God knows. And naturally, so the question is, we thought because implant place nothing in this particular case, we all agree that the answer is most likely no. Would you agree on that? You're not saying convincingly. I mean, how many of you would say yes, you consider implants? Come on, just talk to me. No one? I'll move on. Okay. Well, put it this way. When you look at the high smile line, when you look at the position of the bone here, okay, and that's lower than here, okay, look at the papilla, there's long conical crowns, and you already have loss of interdental papilla here. Can you see that? Papilla. Okay, the chances are the lateral papilla is a lot higher than the mesial papilla.
Yeah.
That makes sense?
Yeah.
You're more prone to lose papilla for this patient. You're more prone to lose bone, intercrestal bone, which holds the papilla. So it is an aesthetic risk. Okay. So what we normally would do, let me ask you a different question. If you had 2 free and 2 missing, where would you place the implant in the high smile? Would you place it in the area of 2 or the area of 2 free and consider pontic? Naturally, you place it in the area of 2 free, right? So you can develop the pontic on the area of 2. It's more, reducing aesthetic risk. Okay, let's go to the next one. treatment sequence. So we stabilize. So this is 14, 15 years old stabilized. Patient's been very good hygiene patient. Okay. Diagnostic phase, well, you have a temporal bridge for a long time, haven't we? And then you want to go to a definitive treatment phase. The trouble is, how would you start a treatment plan in this case? Having all the information. That make sense? Okay. All right. How would you treat this patient? In other words, we have all the good old hygiene. Patients she's on a recall program. Everything's gone right for this patient. So how do we start a treatment in this case? What would the best thing? Having said that, we're going to replace it with another resin bond bridgeway. But what would the first thing you would do for this patient before you do the restorative treatment?
So I think Nimesh, it was on the right lines in terms of showing us something aesthetic. Maybe you can trim down those laterals and bond to give her a good idea of aesthetically how you could improve the area, just to get her on side.
And then
teeth whitening, just to pretty much see what we're gonna do there. Yeah,
absolutely.
Once we get the what's the goal? What's the canine gonna look like? Because I think we just spoke about canines, the color and the darkness of the canine and everything. We want to see how lighter we can get the canine.
So what do you think?
Yeah, it came out pretty good. Yeah, so
you're right. So see how simple solutions, just simple thinking, you're getting a really good result. So this basically answers the question. We'll wait another week for the color to stabilize for this patient. Okay, the color of the teeth, correct?
Yeah.
After about a week or 10 days, you can come back, take the shade. And then from here on, we need to look at the final phase of designing the bridge for the missing laterals. So for this patient, she's not doing too bad. Does that make sense?
Yeah.
She's doing very well. So what would be the next stage for us to do for this patient?
Get her to come back once the shade is stabilized, take the metal bridge off, do the fiber bonded work, whether, as you said, just do the cantilever on 1-3 or probably I
agree with you. I agree. Why would you do fiber bonded bridge work? What would you do?
Well, that's what I have tried, tested, and it works. I got enamel there as a great bonding. She has got a metal there for a long time, I know. Just somehow, yes, I had an option of something like Emax or zirconia or something like that. I just don't trust the zirconia bonding as good as I would trust the fiber bonding.
Okay, that's a personal opinion. I will give you.
Yeah, that's just the personal. Yeah, there's nothing. Yeah, people can do the porcelain work. I don't have an issue. But
keep going. I'll just get water.
Yeah, but personally, with my experience, I've done fair few cases with the replacement of lateral, and for last 7 to 8 years, touch wood. One case came just today. It was done 6 years back with no touch-ups. It's been going really good. So,
Nimesh, what's your gingival health like with the bonding?
Perfect, because I think I always put that Teflon tape while I'm building those laterals, and so they can easily put that Oral-B Superfloss through it, or use a water pick or something like that to clean underneath. As long as we create a nice ovate pontic where pretty much they got a nice cleansability there, we should be quite fine. Yeah.
But you can't get away pontic with the fiber bonded bridge work because.
Yeah, I mean, it's tricky, but not the ovate pontic, but at least something cleansable, nicely polished surface. As I said, I would just put a Teflon tape before.
Yeah, okay. But don't forget, she had a bridge for 14 to 15 years.
Yeah, and she has been looking after it. So
So I think she wouldn't want 5 bonded bridge work as a temporary. What else would you use as a temporary?
As a temporary, you can get the aligner just filled. If you want to just get the temporary.
Better than that. Better than that.
Okay.
You're looking at it.
Or her own bridge or something. Are you talking about? Is it?
You're looking at it. What would you use?
Just do bonding on top of the, just cut them down and bond them.
When you take the resin bonded bridge work off, it's a metal. Remember how, you know how to take a metal resin bonded bridge work off? There's a technique, okay? Let's say you took off, it's intact. So why would you use the same bridge? It's a temporary until you have the final.
Of course, you can do that. Yeah.
Yeah. What would happen if you use 5 bonded bridge work and you take impression with 5 bonded? What happens then? Let me help you. All your area is not the same surface, so it's not going to fit. You just beg it apart. It won't fit. So when you take the bridge out, that's what you have.
Yeah.
Okay, that's what you have. And then what really happens is you prepare them, and this is zirconia. This is hot bonded glass fiber. Okay, that's bonded in the mouth. You can see here, and that's on the model. So I would use the old metal resin bonded bridge work as a temporary. Okay.
Yeah, you can.
The only thing I would do, which you can't see in the slides, unfortunately, is to make an ovate pontic. I would build on top of them, like add the resin, the old resin bonded bridge, add resin, and just press his hair and recreate a papilla, which I've done here better, but you can't see that better. Just unfortunately, the changes form very quick, so pictures was not accurate enough. But I would build my ovate pontic, so I would mold the tissues using a composite addition to the old metal ceramic crown, because it's still a glassy phase like an HF. You can sandblast it, put a HF bonding and build it up. So that's why I did here. So then you have a single layer. That's why single, not double. And from here we have a issue which you can see the positioning of it. Then we go and etch it, and we issue it. Okay. Here's my problem: is that can you see the area here? That papilla is not as high as this one as that one, because the bone there couldn't get in there, couldn't get that down. So we cleaned this up, but it still couldn't do it. It's just a amount of length required. So we had to have a bit of a sacrificial of the papilla, which I'm not happy about. But that's pretty good design. That's the design of the type of length which I want to cover. Canal is pretty short, and we didn't want to touch the centrals. I would have been ideal to do on the centrals, but this is the situation we faced. But nevertheless, there's an ovate pontic coming out from the gum for this patient. So that's a zirconia with hot bonded to the actual canines with improved in outline. And this is a very simple step that you can do in your practices. Or just think about the concept of if we did implant supported crowns bilaterally, the biology cost, the financial cost, the patient's trauma, the possibility of aesthetic complications, the biology complications linked with implants, especially in this case, is more than 38%. Okay, so once you get the implant there, everything else goes belly up. So that's the biggest problem. So to me, the first option would be resin bonded bridge work here. The other thing which I want to talk to you about, you can see the contact point is so low. Okay, this is so low. I did accomplish it added on, okay, to be able to do this for the patient. Okay, that's so low. That's really height. Actually, if you squeeze it together, that probably come down a bit more. So the problem was in that position of the contact. So it's a rather difficult case. Right in terms of your papilla position is unpredictable for this patient. It's unpredictable. The best I could do is get the music papilla right because it's good for the eye. Okay. The good thing is she's not really concerned about the dark triangle here. See, you assess the patient's mistakes. I'll blow this whole case in my consulting room. They can see it's 100 times magnified, but they can see it. They can see it, they can comment, they can't see it. You don't want to see them, you don't want to comment, but you need to bring up to their attention. You can say, "But this, no, that's it," or "You're not concerned about it." So that brings the patient's expectations down, or that you meet the expectations front on. Let's look at, so we issued the bridge work. Okay, issued bridge work, as you can see, different angles for this patient. So we talk about ovate pontic the mesh.
Yeah.
Does anyone know what's an ovate pontic? We all know it, or we don't know? Would you like to explain? Anybody else, or you all know ovate pontic? Okay, we all know. Is that all right? Okay.
Yeah. Now give a little refresher. That will be good.
Okay. Ovate pontic is made to the position of an actual, or similar to a tooth. It's actually embedded within the gum to allow a nice emergence profile, rather than simply sitting on a gum, which is modified ridge-lap pontic. Okay. So ovate pontic, you basically refine the gum, and the bridge is fitted into the gum, so you cannot see the junction between whether it's sitting on a gum or it's actually emerging through the gum. It's more stable. But the disadvantages of ovate pontic, what would be the disadvantage of ovate pontic?
Hygiene.
What is it? Sorry, is it?
Hygiene.
Yes, hygiene will be an issue. So patients have really good oral hygiene to be candidate for ovate pontic, right? If the hygiene is very poor, you get a gum irritation because they have to clean that. They have to get the flows right, and it can be also painful, okay? Until you get a keratinized mucosa forming under the pontic, that's different. You know, when you take a bridge out, it's usually red there, right? There's no keratinized gingiva there. Have you noticed that? You've never cleaned that area. So that's W1 important aspect, okay? So we go over here, point is high gum line, high smile line, and good oral hygiene is very important for this patient. So is our smile. Okay, this is about, I think, 12 months post-op. And we could probably do a bit more of the whitening. It's just happy to do whitening. Okay, that's just the nature of the game. We could have made the lateral a little bit more, less value, but that's how it is. So let's go back a little bit more. Here's the face. Yeah, the face, aren't we? Doesn't look too bad. Doesn't look too bad. So when you think about it, for the patients, she had orthodontics, more dental treatment. People do wear out from dental treatment. Do you ever realize that? They actually get tired of having dental treatment. So, they have to come in, but, someone says, maybe I could have done this work better. And I could say, probably I could have done this better. Maybe I could open the bite slightly and recreate more room for the papilla. But nevertheless, there's always room for improvement, no matter what. What would you think is the, when we look at resin model bridge work, is contraindications? I mean, to implant therapy, like most indications. One would be implant therapy, like it's contraindicated in young patient or specific medical site-specific reasons. Or another one would be patients who have middle intonation. I think low biologic cost is extremely important. I would say short treatment time is fantastic for most patients. And lastly, design considerations. Designing a bridge work, resin bordered fixed partial prosthesis is very simple, and yet it needs to be considered in a real morph, not to be taken lightly. We like to talk about the initial case where we talk with Catherine and Bashir, where patient's going to the right side and is moving teeth, which is understandable. Perhaps the occlusion needs to be modified to reduce the orthodontic forces on the canine teeth. Perhaps we're going to have a shared occlusion that goes to the lateral premolars as well. But nevertheless, besides design, what will be a most important thing in resin bonded bridge work? What is it that actually sticks the resin bonded bridge work to the tooth? What is it? What do we need to get adhesion on a tooth? Jennifer. Jennifer. Are you hearing the question?
Sorry, we'll just repeat the question. What do we need to get?
What do we need for resin bond or bridge work to bond to the tooth?
Enamel.
Enamel. Okay, enamel and lots of it, right?
Yes.
Right, enamel. So where would you not consider resin bond or bridge work?
Maybe in erosion cases or.
Lack of enamel.
Yeah.
Okay, lack of enamel. Can you redesign round tooth? It's just a lack of enamel, but it's got about 70% enamel. Probably can. There's a number of techniques of doing it, but that's outside how this terminology gets discussed in my course for the mini residency. But what else do we need? You see, there's a lot of factors in there. Why do those bridges last all these years? Can someone tell me? Let's go back. Here's a clue for you. Hang on, there's a clue. Here's a clue for you. What do you think that shows you here? What does this picture show you?
Well, you're trying to show the lateral excursion movement. We can see there's not too much of a high contact when she is actually moving. That's what you're trying to show,
What?
if I'm not wrong.
On what?
On the lateral, is I think.
That's right. So you cannot have any guiding contact and minimal centric contact during maximum clenching on lateral. Because the chances are the reason that these two have moved, patient was actually having a contact on lateral. So Catherine,
Yes.
right. So to answer the question of you and Said Bashir is the fact that patient was going to lateral is a movement, and she was most likely loading lateral, which caused an orthodontic movement. Is the whole picture becoming apparent?
I think the finished slide is amazing because the right side of the occlusion is completely corrected as we compare to the previous one, that there's a metal showing and a slight lateral open bite. So by adjusting the new bridge, you actually achieve that amazingly both sides bilaterally.
Okay. Well, yes, but that's what really happened in terms of, so there's a space here, not loading it, but previously it was most likely with loading the lateral incisor, which was part of the orthodontic treatment. Now, coming back, we talk about indication design, okay? Now, this is the latest article, 2020, okay, came in a Pro Journal, open today, and it's a perfect article about this webinar. So without much ado, I put in here, and 10 years, 10 patients, small number of patients, but nevertheless, it's a retrospective study, which is sometimes I prefer than prospective study, because we're doing prospective studies, too much controls, too much this, too much that, of course it'll work. If the retrospective studies is just as important because you didn't think of a lot of things, by looking back, gee, it worked, I wonder why, so you start thinking about it. But nevertheless, it's a viable long-term treatment option for a basic single anterior, that's lateral or a central. In certain situations, even canine, okay, in certain situations. Now, but the best article is Matthias Kern, who's a good colleague of mine in Germany. He wrote the article like Kern Protocol, and this is 2016 journal, and it was published 17 by 16 journal in the Journal of Dentistry, where you need to establish the dynamic occlusion prior to debonding at sufficient level by guides lateral. So deep bites, of course, it's possible because it depends how you open them, how you have your excursive movements. Okay, you cannot have occlusion forces direct on the ponting. You can't have it. Okay. Now we got no consistency how you prepare them. So in this protocol, it's got a little. I'll show you later on. It's like a little, two little blob, one little blob in a single area that stabilizes it. He uses Panavian and just a zirconia anomaly to just bond on. I'm not comfortable with that. I mean, the mesh says not comfortable with that. I'm not comfortable with that procedure. So he's got 10-year studies. So has the group, the Regina Stadler's group, and Thomas' group on doing just a single bonded procedure. I'm not happy with that. So to me, I would be hot bonding my inside. That won't affect the fit. I'm fine because I can bond composite enamel, and naturally enamel, the composite also bonded to a H ceramic glass, which is bonded to the zirconia. So 10-year and 15-year survival rates, 95. 95 for 10 and 15. It's after 18 years, it dropped to 81%. Now, I don't have a single implant study that gives me that success rate. Naturally, selected case. The double retainer bridge works have the highest failure rate. Why? Why, Umesh?
I think we're not playing around the gum and the bone there by doing this. I think that's what my simple logic says. Less you play around, less you poke around, the better it is, and that's what's keeping this.
All right, let's ask Isidore. Isidore, what do you think? Why double retainer reservoir bridge would be more failure than single retainer reservoir bridge work?
Oh, sorry. Yeah, sorry. Go ahead.
Sorry, Zach, please repeat that question.
Single retainer reservoir bridge works, I have higher success rate than double retainer on the bridge work.
Opposing forces.
You've got two different forces on the same, and they fight each other. I guess it's like it's just forces from two different sides.
Okay.
You don't get that flexibility. I guess with a single bond, you've got movement, you've got flexibility. Whereas with both sides, it's got to give somewhere.
All right. Okay. And what's the weakest bond?
TNT.
What is the weakest bond in the whole thing? What is the weakest link in the whole thing? What's the weakest link of the bonded retainer to what's the weakest link?
Contact area, contact of bonding. Is that what you're coming to?
Which is
The pontic.
the pontic? No, we're talking about retainer. When you bond porcelain veneer to enamel, have you ever had a deep bonded porcelain veneer?
No, I haven't.
No one had it? I've had one. Okay, I'll take the blunt here, all right? I'll take the whole brunt, okay, now. And I look at porcelain veneer, how do I know if it's an adhesive failure? Or a failure?
Bonded, whether it's on the tooth or on the ceramic. Where do you find the resin?
That's right. Where would you find normally? It would be on the ceramic or on the tooth?
On ceramic.
Ceramic. So you had a failure after all, Umesh. So why did it debond from a tooth? Boy. Okay, let's talk about this. Okay. The most important thing is the bonding adhesion. Okay, that's very important. Once you have adhesion, then also before that, you gotta get all your design correct, your occlusion force, and everything else, because you just want to have a minimal cantilever force on the pontic, and hence the reason for success rate. Okay. Now this 15-year success rate for this particular was aluminum oxide, which is like a procera material, incisor, okay, infiltrated aluminum ceramic, which is far more weaker than actually fully contours zirconia. So that tells you what a great concept this is. You get Matthew's current book, and it's got the book there. I mean, the book goes stabilized. Okay, let's look at the patient now. I think we've done enough in this case. Okay, this is the interview. I like to interview the patients. Is the parents there? Am I talking there?
If you want to listen to your story, okay? No, give me up. Turn towards me. You keep moving away. Guys, keep talking like you look at me, okay? Please, look at me. Look at this. That thing, all right? Okay. Now, Tamara, how are you today?
Now, I'll stop here. I'll go here.
Now, Tamara, how are you today?
Can you hear it?
Thank you.
Yeah.
You look good. Now, you know what I've done today, right? We have done two small type of Maryland bridges, replace the two missing lateral incisors. I think the work was done by Dr. Mahoney. He put the teeth in the right position, so we can finish it for you. Now, was there any pain during my procedure?
No, not at all.
Not at all. Were you thinking that when I talk about bridge work, that you're going to have your teeth cut? Initially, when it was bridge work, you thought your teeth were going to cut, right?
Yeah.
But remember, your dentist has already placed the Melbourne bridge there for almost like 20 years ago, right? Or 15 years ago?
Yeah, 14 years.
14 years ago, and it's lasted so well.
Yeah.
Okay, not all the time we need to replace missing teeth with implants. You have lots of other ways of doing it. Okay, here's a question for you. From the aesthetic point of view, you already have this for a few hours. You went and ate something. Just on aesthetics initially, how do you feel?
I feel like I've got the perfect set of teeth. I can smile and do everything that I need to do, and it feels perfectly normal, and I finally have a smile that I'm happy with, which is great. And yeah, I don't think I could think of anything better than this.
Thank you. Appreciate that. Next question is, was it, when we discussed your treatment plan, was there anything that we didn't cover that we already did for you? Did you go through the whole procedure? You want to discuss that a little bit more for me?
Yeah. So you went through everything from start to finish. I'd have to go through and talking through step by step. So I got really comfortable with everything, and didn't have any questions. And yeah, the procedure was really easy.
My pleasure, my pleasure. We probably have to ask a question, Mum, right? I think it's Mum. Mum, what do you think? You can see, what do you think, Mum?
I'm really, really happy with the whole process. Yeah, we've been through a lot with Tamara with her now, and
People are worn out.
I never knew what was going to happen at the end, but I couldn't be more pleased with the outcome. It's better than what I expected it was going to be, and I'm so happy for her.
Well, I
You see, Mum has missing laterals.
And you know, your husband, your father as well being here.
Beautiful lady.
I think you've been very supportive parents to help her to be able
Well,
to.
we started the process and we thought it was our job to help her finish the process.
I know, but this is the caring part that's really important. I think she's a beautiful girl. You have fabulous parents, both of you. It's wonderful. Here you are. There you are. We have to work together. Okay. It's a big family affair, isn't it? Really?
Okay. So what I'm trying to explain is that you need to look at the patient first. Preserve biology. Think of the simplest way and reduce biological cost. So treatment was done simply with the least amount of complication and with the longest possible predictability. It's called feasibility. Have I got any question I can answer for you?
Sarkis, what is hot bonding?
Okay, hot bonding is incisor zirconia. I did my thesis on this, so I'm pretty well, I've been doing it for a long time. If you've been in our surgery, if you've come to our surgery, on the wall it's got my thesis with lots of, it's got my poster with a lot of spelling mistakes. So come and have a read them. And it tells you all the hot bonds. So putting out, minimally, if you do it properly, you can have even minimal 10 micron of glass that's evenly distributed. And then you can sandblast it. Now, Alex, my expression, has a brilliant job. So he's the only one I trust to do this correctly. If he can't do it, I'll have to do it. I haven't got time, but normally he does it very well for me. So it's a minimal 10 micron, maximum 60 micron, okay? But if you sandblast, you bring it back to about 10 micron. So you need to look at the stuff like nice, when it's etched with hydrofluoric acid for about 30 seconds. You can't actually do more than that. You get this nice phospholate inside of the zirconia. I'm really happy. Don't have a problem. A lot of them, quite a lot of them. I do full reconstructions using that. In the case, the trouble is that I will use zirconia only in this case. So anything else I do full reconstruction, if it's all to do with bonding to residual numbers, not subgingival, it'll be probably most likely Emax or some of the hybrid type of resin ceramics or whatever it is. But the issue is that in this case, zirconia is the best indication. It's the only time I will use zirconia is to this sort of work with a hot bond, which I'm really, really happy with.
So, Sarkis, what if this was a deep bite case?
It's no problem.
And not a problem, because if the contact is many times the canine's pretty much lower canine is hitting onto the upper canine on the palatal, and we don't have too much of a room there.
When you say deep bite.
Yeah, deep bite. Yeah.
Right. Class 2 D1, class 2 D2.
Yeah, but either of it. Div 2, let's say Div 2.
Yeah. Okay. What's the lateral crucial class 2 D2? Catherine. What's the lateral crucial class 2 D2? Which of is guarding class 2 D2 laterally?
Me? Oh, sorry, I wasn't listening.
Come back to you. Class 2 D2. Lateral crucial occlusion. Isidore, you too. Which tooth is being guarded? Which tooth is guarding class 2 D2? You're placing the laterals, right? Okay, it doesn't really make a difference. I want to ask the question. Which tooth is guarding during class 2 D2? Nimesh, you've done your jaw in your mouth. Are you class 2 D2?
Canine.
Are you sure?
Maybe some, no. I'll quit. Yeah.
The central incisor?
Central.
No.
No.
Usually premolar on distal canine, so your lateral's clear. You're gonna think how it works.
No, I'm not talking about the lateral. I mean, class 2 Div 2 you can think, but I'm talking about a situation where there is a completely overclose bite and the lower canine is hitting onto the upper canine, where I don't have the room to put.
How would you create a room?
Well, I don't want to trim anything. I can if I.
Room.
Okay.
How would you create it?
Drill the palatal away, but then I lose my enamel there.
Yeah, that's what I'm saying. How would you create it?
I normally just sometimes, that's why probably sometimes I go composite with the fiber bonding, and I'll just put a little composite on the labial if I have to. I know it's not ideal, but if the lip line is promising, I might even go slightly on labial.
No.
If there is a lower lip line, not like a gummy smile, I can't go with that.
You wouldn't do that. Don't worry about aesthetics. How would
No?
you
Okay.
be a retainer?
Yes. So do you mean that to build the posterior support, so to raise the premolar part so the interior doesn't go in contact?
That's an overkill, but there's a point taken. That's an overkill. Or better than that. How would you create a room in your cingulum area to place a retainer? How thick should the retainer be?
Are you going in terms of, can I drill it back a little bit? Is that what you're saying? About 0.5 of a millimeter or something?
Retainer is about 0.5 millimeters. Not here, usually it's 0.5 millimeter at least. Okay. Now, how would you create 0.5 millimeter space?
Not drilling the opposing tooth, are you?
Not drilling. How?
No drilling.
No. How?
No idea.
Catherine?
Will you build deliberately create the canine guidance, or will you build the cingulum area?
We did the, yeah, how would would you create area here? How did this do it? You grind the teeth in those days, but what would you do now? Victor, talk to me. Oh, hang on, I'm gonna mute you. Wait, go ahead, Victor. Now I can hear you. Go. Victor, talk to me. Can you unmute yourself? I'll unmute you. Hang on, I'll unmute you. Go ahead. Yep, go ahead, Victor. Can't hear you. I can't hear you, Victor.
Thanks.
Yep, go ahead. Now I can hear you now. Go ahead.
No, can't hear him.
I can't hear you. Can't hear you. I can't hear you. Go ahead. I'll unmute you. I've unmuted you, right? You go ahead.
Can't hear him.
Can't hear it, can't hear it. Yeah, go ahead. Try to. Okay. Victor, no luck? Any other takers? Isidora. I'll wait for Victor to come around. Isidora.
He's gone. Where is Isidoro?
All right. Alicia. Alicia? Are you there? Okay. No. Okay, Prudential Dental. Go for it.
Can you build on the canine area, the upper canine where the rest is?
Say it again, I'm sorry. Say it again.
Where the rest is on the 1, 3, and 2, 3. Can you?
How can you create a space in the canine area, cingulum area? How can you create a space with that cutting feet? 0.5 millimeter.
You make the rest to take the bite where the bonding is on the 1, 3, and 2, 3.
And then? Okay, let me put it this way. It's okay. It's a complex question. See, if you build on those cingulum, it's a bit of a composite. Okay, a little bit of composite, like 0.5 millimeter. There's a good chance that cannot intrude 0.5 millimeter after about 2 weeks. Okay, there may be some post-eruption, but that will intrude 0.5 millimeter. That's your space. And being so confident, I will go ahead and design my bridge work exactly 0.5 millimeters. I will cement it exactly 0.5 millimeters. And after 2 weeks, it'll come back being useful. Is that clear? I'm that comfortable about it because I've done a lot of this. So the fact of the matter is, we talked about the dial technique last week, and this is why I'm putting this in connection. There's a reason in the program, in the residency program, people tell me, oh, I know about diagnosis and treatment planning. I know about taking photos. I just want to do that part or other part. It's all designed to interconnect with one another. It's a knowledge that's compounding from one module to the other until you get to the final module, because you can't think otherwise. You'll be lost. This is the reason why it looks very simple, but when you look at the rationale behind the treatment plan, it tells you very interestingly why things happen. You can see on the right side here, canine moved orthodontically. That's why the pontic rotated out. Whereas here, nothing happened. The canine didn't move, pontic stayed. Okay? And there was some bridge bone remodeling, but more or less you lost the papilla because it moved out. There's no compression of the papilla. So all these little things are important to consider. Okay? So clear. Why we use zirconia? Why do we use metal? We could use metal. Zirconia basically in this case replaces metal because we need what was the important part is the contact area. We want and at least 4 millimeter square contact area, 2 millimeter thickness all around. If it's a Emax, it had to be at least 6 millimeter thickness. Of course you can do Emax, but you need 6 millimeter. Cannot show we haven't got that. So all these little things are very important to formulate a treatment plan and simplify for our patients. Any other questions I can help you with?
No, that's great.
Well, thank you so much. I've enjoyed all your company. Thank you all. Thank you all.
Thank you. Thank you, Dr. Sarkis.
Thank you. Thank you. Okay. And this is recorded, so it'll be back on the college side. I want to thank you so much for being with the team and with the college. And do ask your friends to join us. We've got the last webinar in 2 weeks' time, and that's the trigeminal white spot lesions. If you don't know, I suggest you join in. It's interesting. It's another one. It's a very interesting lecture. Thank you so much. You have a good day.
Good evening.
Thank you.
Yeah.
Bye bye. Thank you. Thank you, son.